Welcome to Endodontics Part 2, where we'll look at the treatment and armamentarium involved in a endodontic treatment. This slide presentation is directed to dental assisting students. Let's first look at the different types of endodontic treatment. Pulp capping, indirect and direct, is considered by textbooks endodontic treatment, and we did look at this in the last presentation, Endodontics Part 1. Also a pulpotomy and then pulpectomy, and we will look at these in detail. We're going to be looking at the pulpectomy. So in reviewing, pulp capping is the use of a resin-modified glass ionomer to seal nearly exposed or minimally exposed pulp in the pulp chamber, and it allows the pulp a chance to heal. It's considered a conservative type of treatment that works in many cases. A pulpotomy is the partial removal of pulp in primary teeth, and it works in primary teeth. I asked a pediatric dentist one time, and she said because it does, but also because primary teeth will exfoliate, they don't have the longevity of permanent teeth. So more than likely, if a pulpotomy was performed in a permanent tooth, there would be infection and reoccurring pulpal conditions. So pulpotomies are performed in primary teeth. So the endodontic treatment of pulpectomy, which is the complete removal of the pulp within the pulp chamber and the pulpal canals, also known as endo treatment or root canal therapy. You can see there are a variety of steps for a pulpectomy, or we will just say endo treatment, which includes anesthesia, isolation, access, excavate decay, extirpation, debridement, shaping canals, irrigation, drying canals, obturation, a temporary restoration. We will also look at whether endodontic treatment will be performed in one sitting or two sittings, one appointment or two appointments, meaning. And in many cases, the endodontic treatment is performed in one appointment. And reason maybe for two appointments is if the tooth has been hurting the patient, if there's been a severe chronic toothache, or the decay was very deep, and so the endodontist feels that this tooth would have better results if it was treated in two appointments. Many endodontists use a microscope, which is wonderful technology in endodontics. It gives the endodontist, the dentist, a very close-up view into the pulpal canal, into the pulpal chamber, and partially into the canal, but more so into the pulpal chamber. Those canals, remember, are way down into the alveolar process, so they do not get to see all the way down to the apex. That's why we have radiographic images. But a microscope has been very, very helpful for endodontic treatment. Another diagnostic aid that's really important is a diagnostic quality periapical image. So with a periapical image for endodontic treatment, we want to make sure that it has good vertical angulation, that it's not foreshortened, which would shorten the tooth, and it's not elongated, which of course would present a very long tooth. And these are critical because there are, in this slide you see, this is an intra-canal instrument, and it's very critical that this instrument be used at the proper length. And then you'll see at the end of the endo treatment there is a periapical image to verify the filling or the obturation of the pulpal canals. Here's a look at an endo tray setup in Armamentarium that's used in a dental assisting lab classroom. But in endo treatment in an office, there are a variety of instruments and a variety of armamentarium that is going to be used to complete endodontic treatment. One of the first steps is to anesthetize the tooth. So the endodontist or the dentist usually will anesthetize with local anesthesia in the traditional manner. However, sometimes the tooth does not become fully anesthetized, and that's because of this difference in pH between the infection and the local anesthetic solution. So many times once the tooth is opened, and you'll see that in a couple of slides, the dentist, the endodontist will give an intrapulpal injection. So they actually place the anesthetic needle into the pulp chamber, into the canal, and deposit the anesthetic solution. Sometimes the patient feels a sting for really few seconds, and then though the anesthesia has taken effect directly in that area. Isolation is a single tooth isolation, so this is kind of your traditional dental dam, or some companies make dental dams that already have a plastic frame, already has one hole in the dental dam, and you simply place it all in one piece and with a clamp. So very, very helpful there. Access and excavating decay. So access could be by the endodontist's favorite burr. And sorry, these are got a little something on them. Sorry about that. Most of the time, a surgical length is used either in the friction grip and or the latch because they are placing and accessing deep into the pulp chamber. So we have a few millimeters of length there. Access is for anterior teeth through the lingual surface into the pulp chamber and then into the canal, and for posterior teeth through the occlusal surface. Another instrument that may be used would be an endo explorer. The working end is much longer than our typical explorers because of that depth of the pulp chamber and partially into the canal that the endodontist may want to probe. Also, locking cotton forceps are very helpful because there's going to be some small instruments and armamentarium that's used to carry to the oral cavity, and so having a locking forceps can be very helpful. To remove decay, besides the handpiece and burr, surgical length burr, they may use a spoon excavator. So these working ends of the spoon excavators are also long to be able to be placed down into the pulp chamber, and we have a large and a small. Next we have intra-canal hand instruments. We have broaches, we have files, we have reamers, and these instruments can these you see are mostly hand instruments, although here we have some intra-canal instruments that will be placed into a latch handpiece or a slow speed. So they can be used into a latch type handpiece. And this is one type of an organizer. If this would to be used at chair side, of course it needs to remain sterile, and then all of this would have to be sterilized. So these types of organizers might be good just to hold your hand instruments, and while setting up you want to take from there, and this is only for organization. Let's look at these various intracanal instruments. So we have a broach, which actually has little triangles off of the working end. And then we have a file, which is kind of like a screw where it's wound at the end, kind of tightly wound, where a reamer has some space. There are also Headstrom files, K files, and it's really up to the endodontist either how they were trained, what kind of technique they're going to use. Sometimes they use a file and a reamer, and sometimes there is a need for a broach. Here's another very popular setup where the files, reamers, broaches are placed in a piece of foam. This would be used only on one patient and discarded, so very nice for maintaining infection control. It's on a ring, so either the endodontist can hold it or the assistant, and then there is a millimeter ruler which will help to determine the length of the intracanal hand instruments. The use of a broach is for part of the procedure called extirpation. This doesn't always happen. It depends on the condition of the tooth. So sometimes when the endodontist opens the tooth, gains access, and is in the pulp chamber and partially into the canals, there is no matter, M-A-T-T-E-R, that exudes from the pulp chamber and the pulpal canal. Because we know in natural state there are blood vessels and nerve fibers that are in the pulp chamber and canal. But as a tooth abscesses, the nerve fibers and blood vessels transform really into a gas. And sometimes it's that gas that creates pressure and a toothache for a patient. So, and then that dissipates, and so when the tooth is open, there's nothing there in the pulp chamber or the pulpal canals. If there is some seepage or bleeding, there may still be some residual pulpal tissue. So a barbed broach with a hand instrument, it's actually wound or screwed down, so to speak, the motion into the canal, and then it is rotated out of the canal, and sometimes a little bit of fibers can actually show. So extirpation is the removal of remaining pulp tissue. To shape the canals, and part of debridement and shaping the canals, smoothing them and enlarging them, then the file, intracanal instrument, the file or the reamer could be used. So they come in various lengths, and as do teeth are in various lengths. So it's important that the endodontist determines the lengths of the intracanal instruments so that they are clearing, smoothing, shaping the canal at the proper length. Let me just go down to this picture. This is what happens if they are not. You could have perforation of the root of the canal. It could happen that the file is just way too long and just comes out the end of the apex. Not good situation. So I'm going to put a big X here. So that's why a radiographic image that is not foreshortened or elongated is very important. Another instrument that could be used to determine lengths is an apex locator. This works kind of like sonar in that a file is attached, and then you have a ground, little clip to the patient's lip, and then as the file is put inside the tooth, the apex locator gets a reading. And so that will determine how long, what the measurement is for the working length of the file or reamer. And then a stopper can be used with the millimeter ruler to measure the reamers or files to all of those lengths. Sometimes during the actual determining, once the length's been determined, the endodontist wants to verify that. So a radiographic image by either sensor or film will be taken, and you can see that you can use, there are film holders or sensor holders for endodontic treatment. So this can be a challenge for the new dental assistant, but when you get really good at, usually at bisecting, because you really can't see what you're doing, but you know, unless you use an XCP or a paralleling type of device, you'll be the expert in the office. There are grids that can be put on a film, and I have only seen this used once, but I think it's very interesting to me because then the endodontist could use this as a measurement. And I've also seen some software for digital imaging. And that's how you determine the length of the intracanals, and it's very important that it be done accurately. So this would be called the working PA. They're going to take an image to verify the length of canals. Occasionally you'll have a canal that is not visible, and so perhaps a burr known as a Gates Glidden or a piezo burr are used when there's internal resorption. And this is when a canal has calcified. Now, for some people, this is just a natural condition. And if the endodontist wants to open the canal, they may attempt to open it all the way to the apex with a Gates Glidden or a piezo burr. Otherwise, there may have to be another type of endodontic treatment that will be discussed in part 3. A little hook there for you that maybe you'll come back and look at part 3. This is just an image of another of a molar. Now look at this already completed endo treatment. You know, we learn in dental assisting programs that typically a mandibular molar has 2 roots. But look at this tooth, how it also has 2 canals. So taking a really quality radiographic image is really important for the endodontist to see that. Next, after the use of the intracanal instruments for debridement and enlarging and shaping the canals, the endodontist will irrigate. The endodontist will irrigate usually with a diluted sodium hypochlorite, although there are other irrigation solutions that can be used. And this is bleach, so you want to be very careful that this does not touch the tissues of the patient. After drying the canal, after irrigating the canals, then they can be dried with absorbent paper points. And in California, the RDA can dry the canals after the DDS endodontist irrigates the canals. Now, if the tooth has had a lot of infection, has been very painful to the patient, the endodontist may wait to complete the endodontic treatment. Therefore, a second appointment would be warranted. Between appointments, there could be medication placed in the pulp chamber or just a dry cotton pellet, which is actually the preferred method. The medicating of a tooth is somewhat controversial in that many times a formocreosalt, a formaldehyde creosote solution, is used on a cotton pellet. This is very caustic. Some orthodontists and some orthodontic treatment feel that this, quote, sterilizes the canal, while other endodontists feel it's a very old-fashioned technique that they see no difference in their endodontic result. And so the dry cotton pellet is preferred and a temporary restoration is placed on a tooth. So again, we either have the completion of the endo treatment or we have this medicating or preferably dry cotton. So let's go on to say if there were 2 appointments. The next appointment, they may not anesthetize the tooth if it's been calm. A dental dam clamp can be uncomfortable, so maybe they place a little topical in that area. They may remove the temporary restoration and the cotton with a endodontic spoon excavator, and then of course clear that area, and there would be the access. They then continue or re-debris shaping using the files and reamers, and then also want to make sure that the lengths are correct. Certainly it's been noted in the chart, but they may take additional working PAs to verify the length. Again, they would irrigate and dry the canals. Now, this would be the point that if it is in one appointment, then the next step would be obturation with gutta percha and sealer. And so obturation is the filling of the canal, and gutta percha is a rubbery substance that is used with endodontic sealer. I know this bottles are really old-fashioned. We've had this in our program a long time ago. Certainly there are a variety of root canal sealers, cements on the market. But these gutta percha, or this gutta percha, would be sized with the length of the canal and placed into the canal. So to make sure that the canal is full, they could use an endo spreader to laterally condense the gutta percha. They might use an endo plugger to actually pack the material firmly into the canal, and a Lentulo spiral would be used to place sealer. And usually the sealer is placed first, and then the endo spreader and endo plugger is used when the gutta percha is placed. Now, you can see here gutta percha is usually a little longer than the tooth. This is quite a bit longer, but usually they're not quite that long. In order to soften gutta percha and sear it or trim it, an endodontist could use this little machine. Is called a heat and seal. So it has a tip that can actually go down into the canal, or just sear off the end at the access, and then it's soft enough that the endodontist could use a condenser, endo condenser, or this is a Glix number 1. It has a condenser on one end, plastic instrument on the other. If they're not using a heat and seal, some GPs have actually used a flame to heat an instrument, and then you just sear it off. Of course, they have to be very careful for the patient, not to get that heated instrument close to the gingiva. And then we will have our final PA that's taken to verify the length of the gutta percha and the obturation of the canal. From there, a temporary restorative material could be placed, such as CAVATE, or there's lots of different, this is one that's been on the market for a long time. There's lots of different temporary restorative materials. This comes in a putty. It's all ready to go. Use a plastic instrument to seal the access. Or an IRM could be used, or a ZOE. This is IRM is one brand, but there's other ZOEs. And then usually about a week or so later, sometimes even a month later, a final restoration, final restorative treatment would be placed. Now the tooth may be so fractured or had been decayed that a crown might be needed. This is one of my crowns. Or maybe it was just discolored, and so a veneer could be placed. Or to be more conservative, perhaps internal bleaching. Now this is an endodontically treated tooth. It has to be endodontically treated, and a bleaching compound or liquid called superoxal. So it's has a high percentage of sodium hypochlorite, is placed on a little cotton pellet and then placed in the tooth. It is sealed with a temporary restoration, and then sometimes a week later or a couple of days later, the patient comes in to see if the enamel has actually changed color. So very similar to whitening, except this is a super concentrated form of sodium hypochlorite, and peroxide, and it's placed internally, where whitening, of course, is as external on the tooth. So for some patients, this internal bleaching may work to change the aesthetics. So that completes Endodontics Part 2, the treatment and armamentarium. I thank you for listening. I hope you've learned a lot, or maybe this is a good review for you, and I hope you will stay tuned for Endodontics Part 3. Thank you.